Good evening once again, all the young orthopedic surgeons who are interested in Ilizarov. The only advantage with Ilizarov is we can make the patient walk on a broken bone. So let us know the basic principles of this Ilizarov. The flow chart goes like this. Position of the limb is very crucial here. Safe zones, one should know very well about the safe zones. The types of the tips of the wires, when to use and where to use. And what are the reference wires, which I always try to find out very confusing to the youngsters. And what are the use of drop wires. And how do you stretch the skin while passing the wires, how to avoid the stiffness of the joints when you really exactly stretch the skin when passing the wires. And what are the trajectories of the pins, so that you can avoid oblique pins, obliquely trajected pins, and to avoid unstable fixation. And you assess the stability of the fracture. And once you get the stability, you should know the loading effect on the fracture through the pin. Once you know how to stabilize the fracture, you should know the amount of rigidity in relation to limb to the ring. That's very crucial here. And what is important is the clotted post and the use of the hemispherical washer. And a few tips about the translation and working length and the use of hinges and twisted plates and the motor. This is the flow chart I usually follow for basic principles of the Ilizarov. Before that, the position of the part is very crucial. We always use some bolsters in the form of folded drape or kidney trays wrapped in a drape again, and then some wooden blocks. I used to start with the wooden blocks, a concave surface of wooden blocks to accommodate the lower part of the thigh and the ankle joint, and then sandbags are commonly used. But the problem with them is all of them are very hard and all of them are really loose, really dense. We really can't see the wires going when you are supported by these blocks. So I got an idea how to use these blocks, which are very lightweight, and then they are not deforming. Suppose you take a towel, folded towel, over a period of time, it gets deformed. A circular pillow will become a flat one, and then it's radiolucent. That's one big advantage of these bolsters, that you can see clearly on a C-arm. The image is as good as you are not doing, and nothing is there between the limb and the beam. And they're easily prepared, designed and prepared, and then you can make them in any forms. So these are the bolsters which are used to keep the limb stable, so that our hands are free, and we can play with the rings and wires. This is the profile view of the limb with bolsters beneath the knee joint and bolsters beneath the heel. Both of them are radiolucent. You can easily take the C-arm images clearly without any problem. And this is the frontal view from above. And this position of the limb is very crucial. Once you get a good positioning of the limb, it's easier to pass the framework of the Ilizarov. Then comes the safe zone, the basic principles of Ilizarov. Somebody puts a question, what is the basic principle of the Ilizarov? I always say it's a controlled distraction osteogenesis. It's always controlled, but it's not exact osteogenesis. It's the histiogenesis, because you're stretching the skin and then the rest of the soft tissues around the bone. So it's a histiogenesis, a control. You can say distraction or compression of histiogenesis. Then why is in Ilizarov? There's a very crucial question to be answered. They maintain the bone fragments. Akanksha, how can I take out the template on the right side?
Which template?
The template. I am able to see all this. Okay, I can minimize them. Okay, right.
You can just go to view, sir, and then you can click on hide self view if you would like, sir.
I can hide it now, right?
Yes, sir.
So to maintain the bone fragments in position and to maintain the bone rigidity of the fragments again in position, and the wires are helpful or meant to keep the hop pins or fold pins away from the soft tissues, so that you get good amount of what you call telescoping effect of the soft tissues through the wires which are fixed to the rings. The advantage of wires is that it will destroy very little bone and bone marrow. If you tension them, it decreases the vibration, increases the elasticity, and prevents the soft tissue damage along with the bone destruction. So once you remove them, there is a little bone or soft tissue defect or destruction. So that's a big advantage of wires over the shunt pins. So let's talk about safe zone. In the upper third of the leg, I am just confining myself to the upper third of the leg component only this time. In the upper third of the leg, you have the cross-sectional view. You have the bones, tibia and fibula, and the anterolateral compartment is very little there in the upper third. And you have the medial as well as lateral gastrocnemius muscles or heads of the gastrocnemius, and you have the vessels, and then common perineal nerve is very crucial here. You can pass the wires almost obliquely, in fact, intersecting each other about 45 to 60 degrees also. And the wire on the right side is called reference wire. When I say reference wire, the wire should be parallel to the joint line. That's very crucial. Unless you get that parallel to the joint line, the frame will not be parallel to each other in both AP, in the anterior, posterior, and lateral views. So that we can avoid the neurovascular bundles in this position. We can also use the shunt pin in case there is fracture upper 1/4, where we need to prevent the extension of the disc proximal fragment. That can be neutralized by putting a pin in the form of pin from the first ring or proximal most ring. In the anatomy, you can see that is the head of the fibula, and you can see the common perineal nerve and the iliotibial band. So the safest way of putting the reference wire is through the head of the fibula, or you can go a little anterior to the head of the fibula or superior to the head of the fibula, but never behind the head of the fibula or neck of the fibula. You invariably damage the common perineal nerve. This is very crucial when you are passing the first reference wire. And we go to at the level of tibial tuberosity. You have the bones there, fibula and tibia, and you have the anterolateral compartment well formed, and you have the posterior compartment, both superficial and deep, and you have the neurovascular structures, the anterolateral compartment as well as the posterior compartment. You can pass the wires in the same direction, either mediolaterally or in the transverse direction also, maintaining the angle between the two wires. Now we are very safe. We will not go and interfere with the neurovascular structures. You can also use again the pin, since it is the fracture. If the fracture is involving the upper third, the tibial patellar tendon tends to get this proximal more extension that can be neutralized by passing a pin anteriorly without crossing the posterior cortex. When you come down to middle third of the leg, you have again bones, and then a bigger anterolateral compartment as well as lateral compartment and the posterior compartment, and we have neurovascular structures there, and we can pass the wires in the same way without hindering the vascular supply or neurological supply of the limb. These are the safe zones for the middle third of the leg. When you go down to lower third, it's very easy to pass wires because there's not much musculature. And then we have the bones there again. Anterolateral compartment is very less here, only tendons are there. And you have the lateral compartment, and then both compartments of the posterior component and the neurovascular structures. You can pass the wires in this direction without damaging the neurovascular structures. So these are the safe zones for the leg, where we can get good stability of the fracture, of the containment of the fracture to the bones, and we will not damage the neurovascular structures. And a few tips about trocar tip, tips of the wires. We have only two types of tips available in orthopedics. One is a trocar tip. The other one is a bayonet tip. In the trocar tip, we have three facets where when we drill them through the soft bone, there's nothing, you don't see any bone coming out when you're drilling with a K wire. So we call it as drill in. We don't take any bone, so it's called drill in. But when you go to the sort of harder bone, we need to use a bayonet tip. Vinyl tip has got, if you see them, there are two bevels in opposite direction. The bevels are there to cut the bone, and then we call it as a drill out of the bone. So we use them more harder bone. This is commonly used in the carpenters also, where they have the bevels to cut easily in a hard surface. I always use a pre-assembled frame. The advantage is that it's very less time is spent on this assembling. When patient is given during anesthesia, we can make an assembly of the frame, and it is easier to align the fragments in a straight frame than like I am trained in that way. I got used to that way. Again, this is the frame. The frame should be parallel to the long axis of the limb. There should not be any deviation. That can be achieved only by reference wires which are parallel to the joint surface, both at the knee joint as well as at the ankle joint. So we call them as reference wires there. Then we have some drop wires. When you don't want to use, or when you don't want to have more rings, or when there is no place for the rings, we can make use of the drop wires. Drop wires are generally used with a threaded rod or some sort of post, female post or male post, attached to the ring on either side of the limb, and then pass the wire. That also acts as a stabilizer or supporting to the reduction rings. And you can also use the drop wires along with the olive wires, where we can maintain the fracture in the form of compression through the olive wire. Once you've done that, you should see that we should always, when the reference wires are well placed, parallel to the joint surface, we see the frame is parallel to the long axis of the limb, both frontal view as well as lateral view, as you can see in the radiograph here. So when passing the wires, you should always keep in mind how to bring down the damage to the soft tissues. Otherwise, we should maintain the physiological length of the muscle, so that we should have some maneuvers when you are going through the compartments through the muscle and reaching the bone. This will bring down the amount of joint stiffness when you stretch the joint soft tissues while passing the wires. Like in the case when you're going from anterior posterior, at the level of ankle joint, for example, you need to keep the ankle in as much equinus as possible without disturbing the direction of the fracture. And the wire goes out of the anterior compartment and entering into the posterior compartment, you should keep the limb in dorsiflexion. That means you have to stretch the limbs it will maximum movement in the same direction to avoid the soft tissue contractures while passing the wires. If you're going from posterior to anterior, it's the reverse again. You can see that then, so that you will bring down the amount of soft tissue stretch as well as joint stiffness during the process of rehabilitation. So normally we tend to make multiple holes or multiple attempts into the cortex. That should be avoided because they're all stress risers when somebody wants to bear weight immediately post-operatively. So always better to use one stroke or to learn to put wire in one stroke flush with the ring. Sometimes you can use the wire fixation bolt and the positive wire, a cantilever wire fixation or a eccentric cantilever wire fixation bolt. Then you can pass the wire so that the wire is almost flushing with the both surfaces on either side. But if you make some angulation at the, like suppose you make a 5-degree angulation, it will go up to 15 degrees when it reaches out of the other cortex, where we need to go for a washer. So sometimes some nuts also need to be put, but the wire is not very strong when it is not perpendicular to the long axis of the bone. That is to be avoided. But it's always better to go through the bone and the marrow and outside the cortex. That means one should feel the two cortices, give way of the two cortices when you pass from one particular bone like tibia, near cortex and forecortex. It's better to avoid passing through the cortex. You will not have the feel of going through different cortices. The disadvantage is it acts as a stress riser, or we call it a breach in the cortex. And during the process, since it's a avascular structure, we may go in for a cortical osteomyelitis. Then we need to understand how to get a stable fixation. In this representation or animation, you can see that is the best for to get a horizontal wire, number one. And then we can get a 90 degrees. 90-90 is the best for stability. Since you cannot go 90-90, we have a compromised situation where we need to go in a oblique direction, maintaining the angle between 45 to 60. Given a choice, it is 60 that is more stable than the 40. Less than 45 or 30 is not going to help to get the stable fixation of the fragments. Some people, they try to use parallel wires thinking that they maintain stability. But the problem with that is there is toggling of the bone in horizontal direction because there is no angulation of the wires. So it tend to toggle mediolaterally. So that can be prevented in case you want to go for, you pass the wire obliquely with a 45 degrees angle between the two parallel wires. When you have 30 degrees of angulation between two wires, what happens is, suppose you have wires like this. We think it's very safe to pass the wires because you're not injured any vessels there. But the problem is, again, you have the toggling in the sagittal plane. That means anteroposterior toggling is there. That can be avoided as passing a horizontal wire, keeping those two wires in the position since they are not jeopardizing the vascularity or neurologically. But always better to have them in this direction to get a stable fixation. Can this toggling happen in the coronal plane? Yes, it can also happen in coronal plane when you do like this with less than 30 degrees of angulation between the two wires. You get a toggling
Hello.
of the wires. Hello?
Hello.
Sir, yes,
Hello.
sir.
Hello? Any, shall I pause now or?
Just 1 second.
Please
Sir.
continue, sir. Please continue, sir.
Yes.
Okay then. So there can be toggling of the bone fragments in the coronal plane. Again, that can be avoided when you just replace them in the required direction of the wires. Once you get a stable fixation at 60-60 or 50-50 angulation, you get a stable fixation and the load on the bone will be uniform or even, or evenly concentrated load is there on the bone. But when the angle is less than required, that is around 30 degrees, you get a loading is not concentric, it's uneven, and then there's failure of the fixation. So you get uneven loading on the fragments. People think that the longer the wires from the limb is it allows more elasticity, more vertical migration, vertical compression. That is not the case. You should not have longer wires between the frame and the surface of the limb. It should be ideally 2 fingers breadth anteriorly, about 3 fingers breadth posteriorly, and 2 fingers breadth on either side. That means 2 fingers space between the ring and the surface of the bone, and then two wires in each fragment are the minimum requirement to get a stable fixation. So farther away from the limb to the ring is less rigid and it tends to fail easily, early also. And a few words about the slotted posts. They are very useful. They are meant to have some sort of what I call translation. Then we make use of the hemispherical washers, and that can be demonstrated here clearly. You can see the movement of the post by about 5 to 7 degrees in either direction. So that is helpful to get a phenomenon called puller or pusher when you want to move the fragment in any direction or whichever direction you want. That means you want to bring it down, you have to pull the fragment towards the ring. The basic requirement for that is you should have a pivot wire, only one wire horizontally or vertically, obliquely, whichever direction you want, preferably in the line of pull that acts as a pivot over which the bone gets movements to get required alignment. You can also use the same post to pull away with a pivot wire. It acts as a pusher. The threaded rod will act as the shanch pin will act as a pusher, or threaded pins on the head towards head side will act as a pusher. That way you can get alignment easily. It is easily said in the theory, you can get easy translation unless it is a very acute case. But you can try to do the translation. We pass a wire like that with a stopper, or then you can lift them to the required length, or corresponding holes are maintained. So you want to bring the limb to that level of the ring hole, where we can tight on one side and then try to do tensioning on the other side. The limb moves or the bone moves sagittally. Once you get required surgical movement, we can also go for a coronal movement also with the olive oil, where we take out we loosen the pin screws on the other side and try to tension it there on the opposite side. Then we get required amount of movement. Then we can tighten the previous side white fixation bolt and then go for tensioning again. So we get translation in the both sagittal plane as well as coronal plane. It's easier to set on the PowerPoint, but very difficult to get on the table on a patient. So that is the movement in the coronal plane. This is very crucial. One should have a working length. The working length is very crucial for any plating of the long bones. Similarly, the working length is also very crucial in the Ilizarov frames also. That is the fracture line, and this is the second and third link that is imagined that way. But the ring is far away from the fracture, and the other ring is also very closer to the reduction ring. The number 2 is a reduction ring, and number 3 is a supporting ring. The distance between these two is much narrower than the distance on the right side figure, which has got good working length, where you can take good stability of the fragments, or the supporting will stabilize the reducing ring easily when you have a good working length or a scientifically proved working length. A few words about the hinges. The placement of hinges we can have some other time, where to place the hinges and all. But you should know what are the hinges. They are nothing but female and male posts joined by a nut and bolt, and then applied to the rings, or 5/8 ring or the full ring. But you have hinge, but you should also have a sort of twisted plates, wherein we can motor is attached to that without any disturbance in the plane of the rings. The rings are applied perpendicular to the bone, but rings are not mechanically 90 degrees to the limb. When they are obliquely placed in the mechanical axis, we need to have twisted plates with again washers, conical washers or hemispherical washers, where to get the motor exactly in the one direction only, where we can do the effect of the distraction or compression. In this case, we are trying to close the wedge on the lateral side, and then you can see the motor has acted and hinges become straight, and we get the good reduction of the fracture. At the same time, both rings are parallel to the bone as well as to the mechanical axis or the long axis of the limb. So that's the reason why we need to have twisted plates when you want to go for hinges and to apply motor through the twisted plates. Best wishes to all youngsters. Thank you very much for the chance.